Okay, so today we're going to talk through our multi-system assessment. So our assessment consists of a subjective, objective, analysis, treatment, evaluation, and a plan and review going forward. We do it in this way to relate systems to each other and how they interact, to identify patient problems, to identify precautions and contraindications that may affect our interventions, to determine physiotherapy intervention, and in order to then evaluate our interventions once they've been done. So the first part of our assessment is our subjective assessment, which is our information gathering stage. So within this, we can break it down into 5 sections. So you've got your present condition, which is kind of the reason for admission. Why are they in hospital? You've then got the history of present condition, which is what led them here. So what symptoms did they have? Have they had any investigation? When were these things done? When did they happen? You've then got your past medical history, which is really important. So, have they got any pre existing medical conditions? Have they had any previous surgeries? If so, what are they? Making sure we're finding out about those things. Then, details about any respiratory conditions they've had. If they have any, have they ever had any admissions to hospital? What are their symptoms? What tests have they had? Then we move on to our drug history. So, are they currently on any medications? If so, what are those medications? Are they respiratory specific, such as inhalers or nebulizers? And do they have any allergies at all? Then, lastly, you've got your social history. So, in this, it's finding out what the mobility was like pre admission, what occupation they have, if they work, what do they do, and do they smoke, do they drink, or anything like that. Then we move on to the objective assessment. So you can get this information from your medical notes and from PPM, from ICU charts, from news charts, fluid charts, your own observation and your own objective assessment, specific special tests that you might carry out, and also from other members of staff such as your nursing staff and your medical staff. So we use a multi-system approach when looking at our patients objectively. The areas that we look at are your cardiovascular system, your central nervous system, your renal system, your abdominal GI system, and then obviously your respiratory system. What we'll do is we'll now look at each of these in a bit more detail. Okay, so first we'll look at the cardiovascular system. This can be broken into lots of separate components. The first component we'll look at is the heart rate. A normal resting heart rate in a standard adult should be between 60 to 100 beats per minute. We can look at the rhythm of this heart rate. Is the rhythm normal or abnormal? Sinus rhythm is the normal rhythm of the heart. Tachycardia is a fast heart rate, so anything over 100 beats per minute. Bradycardia is a slow heart rate, so anything under 60 beats per minute, and atrial fibrillation is an irregular and normally fast heartbeat, and it's caused by abnormal electrical impulses in the atria of the heart. Next, we'll have a look at blood pressure. The standard values for a normal adult are in the little circle. Anything below this is considered hypertensive, and anything above this is considered hypertensive. You might find some people run naturally lower or higher than these values, and you should liaise with the patient or medical team to establish the patient's normal baseline. Also be aware that some of the medical interventions and medications that patients may be on can cause fluctuations in blood pressure. If you're unsure of how this will affect your treatment or how your treatment may affect their patient's blood pressure, then just chat to one of the medical team about your concerns. Next, we'll have a look at temperature. So normal ranges for temperature are 36.5 to 38 degrees. Anything over this is considered pyrexial, and anything in between this is called apyrexial, which in other words is normal. Then we'll have a little look at blood results. So the white cell count. An increasing white cell count can be an indicator of an infection. HB, which is your hemoglobin, is the substance that allows for the transport of oxygen throughout the body. To be mindful for physio, if HB is low, people could experience weakness, shortness of breath, and dizziness. And then finally, look at the platelets and clotting. Low platelet count may also be called thrombocytopenia. Low platelets may mean your body can't form clots or as quick or at all, meaning people may continue bleeding or have excessive bleeding after a trauma. Be aware and always check platelets and clotting when suctioning, as there is a bleeding risk. Then we'll have a little look at cardiovascular drugs. So, inotropes are indicated in acute conditions where there is a low cardiac output, such as cardiogenic shock following a myocardial infarction, acute decompensated heart failure, and low cardiac output states after cardiac surgery. Common inotropes include noradrenaline, adrenaline, and milnirone. Beta blockers work mainly by slowing down the heart. They are used to control heart rhythm, treat angina, and reduce high blood pressure. Common beta blockers you may come across include labetalol and bisoprolol. Arrhythmia management drugs. The common one that you will see is amiodarone. There'll be lots of drugs that you don't know and lots of drugs that you don't recognise, and if this is true for you, then just have a little look them up, or ask a medical professional, or ask your educator. Okay, next we'll move on to specialist cardiac measures. Firstly, you've got a PA catheter, and this is a catheter that's inserted into a pulmonary artery. Its purpose is purely diagnostic, and it's used to detect heart failure or sepsis, monitor therapy, and evaluate the effects of drugs. The pulmonary artery catheter allows measurement of pressures in the right atrium, the right ventricle, and the pulmonary artery, and also the filling pressure of the left atrium. Just to let you know, the pulmonary artery catheter is frequently also referred to as a Swan's-Ganz catheter, so you may hear that instead of PA catheter. Next, we have an IABP, which is an intra-aortic balloon pump, and it's a type of therapeutic device. It's used to help your heart pump more blood, and you may need it if your heart is unable to pump enough blood for your body. Just to let you know, for these specialist cardiac measures, patients must remain in bed whilst these are in situ. Okay, so next up we have the renal system. The renal system is really important because it removes waste products and medicines from the body, balances the body's fluids and electrolytes, releases hormones to control blood pressure and to control red blood cell production, and also helps with bone health by controlling calcium and phosphorus levels. In our patients, it's really important that they stay hydrated, as water helps the kidneys remove waste from the blood in the form of urine. Water also helps keep your blood vessels open so that blood can travel freely to your kidneys and deliver essential nutrients to them. If you become dehydrated, then it is more difficult for this delivery system to work. We can measure hydration levels and renal perfusion levels by our hourly urine output. The normal figure is in the circle. Oliguria is decreased urine output, which is less than 300 millilitres in 24 hours. Anuria is no or minimal urine output, and this is usually less than 100 millilitres a day in adults. We can also look at our fluid balance. So fluid balance is a term used to describe the balance of the input and output of fluids in the body to allow correct metabolic processes to function correctly. Oedema is fluid retention within the body. It occurs when the renal system is impaired and can't excrete fluid, and this causes fluid overload in the body and therefore leads to edema. There's different types of edema, such as pulmonary, which is excess fluid collects in the lungs and can make it difficult for a patient to breathe. Peripheral, which affects the peripheries such as feet, legs and hands, and cerebral, which affects the brain. It's really important during our observations that we have a look for signs of edema. Next, we have the central venous pressure and the jugular venous pressure. So central venous pressure is the pressure measured in the central veins close to the heart, and it can indicate the mean right atrial pressure. A jugular venous pressure provides an indirect measure of central venous pressure. Then we move on to drugs. So to try and get rid of edema, patients may be started on medications such as diuretics. These are designed to increase the amount of water and salts expelled from the body as urine. The most common diuretic you'll see is called furosemide, which can be given orally or IV. Next, we'll have a little look at the blood results. So certain blood tests are used to look at kidney function, and the two key ones are urea, which measures how much of the waste product you have in your blood. If your levels are off the normal range, this could mean that either your kidneys or your liver may not be working properly. Creatinine. Creatinine is a waste product that forms when creatine, which is found in your muscle, breaks down. High levels may indicate that your kidneys may not be working properly because they may not be getting rid of this waste product. Lastly, you'll see that there's different types of renal support that a patient may be on. There are lots of different types of renal dialysis and filtration, but the one that you'll come across most commonly on ICU is CVVHD, which is continuous veno-venous hemodiafiltration. You also may hear it referred to as a filter. Essentially, it supports the kidneys and aids them in their role of removing waste from the body. It's a short-term treatment for inpatients with kidney dysfunction and hemodynamic instability. This therapy is performed on ICU, and the indications for its use may be acute kidney injury, fluid overload, metabolic acidosis, electrolyte abnormalities, hyperkalemia, which is high potassium, and hyponatremia, which is low sodium. So the third system we need to look at is the abdominal and gastrointestinal system. Firstly, you can palpate the abdomen and see if it's soft, whether it's firm, whether it's tender, or see whether it's distended. And these can give you an indication of potential pathologies or other underlying causes. One of the most common causes for patients to have a firm or distended or tender abdomen is them not having their bowels open. So it's important to know whether the patient has had their bowels open recently, as if they haven't, then this can be a cause of discomfort and tenderness. Next, have a little look at their feed and whether they're, feeding themselves and can eat and drink, or whether they need other types of feeding, such as artificial feed. An NJ tube, which is a nasojejunal tube, is a soft tube that's put through the nose and goes through the stomach and ends in the jejunum. An NG tube, which is a nasogastric tube, again is a soft tube that's put through the nose, but this goes just down into the stomach. A TPN feed is a total parenteral nutritional feed, and this is where a catheter is placed into a vein and a special nutritional solution is provided through that catheter. So this is known as intravenous feeding. It's usually provided when the gastrointestinal tract is not functioning and it's not able to absorb the nutrients that the body may need. Then you have a PEG feed, which is a percutaneous endoscopic gastronomy. And this is a feeding tube that is put in through your skin and into your stomach, and it allows you to have the nutrients and fluids you need through this. You need to have a little look for absorbing, whether they're absorbing their feed or aspirating their feed. An aspirate less than 500 ml indicates that the patient is absorbing their feed. Observe for abdominal distension and vomiting, as this can be a sign of aspiration. If 2 consecutive aspirates above 500 ml, then the patient's probably not absorbing, and you may need to consider different feeds, such as a TPN feed. Next is incisions and wounds, so just be aware of these as they may cause discomfort and you may need to be aware and adapt your handling as appropriate during sessions. Drains such as Ryle tubes and Robertson drains, again be aware so as not to dislodge them during potential treatments. Drugs, so be aware that certain types of analgesia can make patients constipated, and these are mainly opioids. Laxatives and enemas can be used to treat constipation, but just be aware if the patients have had these prior to your treatment. A PCAS, you may see this on patients' charts, and it stands for patient-controlled analgesia. The patient can deliver the pain relief through a button which they can press by themselves. Again, these are mainly opioid-based, so can be a contributing factor to constipation. And lastly, have a little look at the patient. Are they obese? Are they malnourished? As this can give us an indication of what they might be like in terms of for feeding and things like that. The next area of our assessment to consider is the central nervous system. Firstly, we need to consider alertness. So are they drowsy? Are they sedated? And it's important to determine patients' alertness to aid with treatment decisions. For example, if a patient is heavily sedated or paralysed, they may not have a cough, therefore suctioning may not be as effective and a different method of chest clearance may need to be chosen. Or if they are very drowsy, then they may not be safe to rehab as they may not be able to actively engage in the session. Are they confused? Are they orientated? So ICU can be a very disorientating place. Sometimes it can have no structure and you can lose a grasp of day and night when you're a patient. Delirium is an acute and fluctuating disturbance of consciousness and cognition, and it's a common manifestation of acute brain dysfunction in critically ill patients, and it occurs in up to 80% of the sickest ICU populations. The CAM-ICU is a commonly used score which helps identify delirium and monitor to see if it's resolving. Consider their GCS. So their GCS stands for the Glasgow Coma Scale. It assesses consciousness based on eye, verbal, and motor criteria. Another thing to consider with the central nervous system is intracranial pressure, or ICP. It's the pressure exerted by fluids such as cerebrospinal fluid inside the skull and on the brain tissue. ICP is measured in millimetres of mercury and, at rest, is normally 7 to 15 millimetres of mercury for a supine adult. You need to be aware of intracranial pressure in neurological patients, usually monitored on neurosurgery ICU. The most common use of continuous ICP monitoring is in the management of a severe closed head injury. Just be aware that your treatments may affect intracranial pressure, and a high intracranial pressure may be fatal as it can start pushing the contents of the cranium downwards towards the brainstem, affecting its function. The brainstem is where your breathing, heart rate, blood pressure are all controlled. Ultimately, if the pressure is raised too high, this could be fatal to your patient. Next, you want to have a little look at how they're moving their limbs and the mobility. So looking at how patients move their limbs and mobilise is a good indicator of if they have a new neurological impairment. For example, if someone has a right-sided weakness in both their arm and leg, it may indicate a neurological event has occurred and may warrant further medical investigations. Or similarly, if a patient sits over the edge of the bed for the first time and is slumping to the right and does not have sitting balance, but was previously independent with no underlying conditions, it may also be another sign of a neurological event. When looking at the CNS, we have to have a little look at drugs. So common types of drugs seen on ICU are sedatives. So sedation allows the depression of a patient's awareness of the environment and the reduction of their response to external stimulation. It plays a pivotal role in the care of a critically ill patient and encompasses a wide spectrum of symptom control that will vary between patients and among individuals throughout the course of their illnesses. Common sedatives you may see on ICU are propofol, clonidine, and alfentanil. You can also see paralysing agents. So paralysing drugs are now almost routinely used to produce muscle relaxation in the operating room, but are also commonly used in the ICU. Muscle relaxation to facilitate endotracheal intubation and other invasive techniques are the most common indication of them on ICU. A common paralysis agent you may see is rocuronium. And lastly, are the patients in pain? Finding out if patients are in pain is important as we need to make sure the pain is adequately controlled to ensure they are not in discomfort in physiotherapy sessions, whether that be in respiratory management or rehabilitation, as this may result in a very poor outcome from your session if they are in pain. As physios, we play a very important role in identifying whether a patient is in pain, so make sure you let either the nursing staff or medical staff know if pain has been an issue in your patient session so it can be addressed. Our final system to look at is our respiratory system. Firstly, observe and position. Look at the patient and their positioning. Are they in an optimal position for ventilation? If not, could you consider this as part of your treatment? Good positioning of a patient can greatly affect someone's respiratory system. Next, look at their airway. Patients may be maintaining their own airway and not need extra support, or they may need support with this. An ETT, an endotracheal tube, is a flexible plastic tube that is placed through the mouth into the trachea to maintain an airway and ensure adequate ventilation. Usually they're used during and after surgery to protect the airway against aspiration and most importantly to support breathing. If someone is having difficulty breathing due to pneumonia, a pneumothorax, respiratory failure, or if they're unconscious due to an overdose, stroke, or brain injury, then an endotracheal tube may be placed in to support breathing. Next is a tracheostomy tube, and this is a tube that is inserted into the hole into the trachea to maintain an airway. They can be temporary or they can be permanent. These may be used in long-term intubated patients to assist with ventilator weaning. They may be done in an emergency if an airway is blocked, or may be needed if a patient has a condition which means they cannot effectively maintain their own airway or manage their secretions. An example of this is a high spinal cord injury. Next, look at the mode of ventilation. It's important to see how the patient is ventilating. If the patient is needing a ventilator to assist their breathing, then it is important to know what mode they are on and how this mode is assisting the patient. Common modes include controlled, and these are set up and initiated by the ventilator, supported, which are usually used for patients who are able to breathe spontaneously, and combined, commonly used in patients for maintenance on ventilation and weaning. Next, look at the ventilator settings. Common ventilator settings to be aware of and to document are PEEP, which is positive end expiratory pressure, and it's a pressure that's applied by the ventilator at the end of each breath to ensure that the alveoli are not so prone to collapse. This recruits the closed alveoli in the sick lung and improves oxygenation. Pressure support, which you may have seen written as PS, and this provides a set amount of pressure during inspiration to support a patient who is spontaneously breathing. It allows the patient to utilise their diaphragm and the normal muscles of inspiration rather than the ventilator doing the breath for them. Pressure support eases a patient's ability to overcome the resistance of the endotracheal or tracheostomy tube and is often used during weaning because it decreases the effort of breathing. Next is pressure control, or PC. Pressure control is used to regulate pressures applied during mechanical ventilation. In pressure-controlled breaths, a tidal volume achieved is based on how much volume can be delivered before the pressure control limit is reached. Lastly is TV, or tidal volume, and this is the set amount of air that moves in and out of the lungs with each respiratory cycle. Mechanical ventilation with high tidal volumes may induce or aggravate lung injury in critically ill patients. All of these settings can be manipulated to give more or less support to the patient. As physios, we have an active role in trying to effectively wean patients off ventilation, which involves manipulating these figures to give less support to the patient. Next, we'll talk about oxygen. So FiO2 is the fraction of inspired oxygen and is a percentage of oxygen in the air mixture that is delivered to the patient. Oxygen can be delivered in lots of different ways, and these include nasal cannula, face mask, Venturi, 15 litres non-rebreathe, high flow, which can be via face mask or nasal cannula, CPAP, or invasive ventilation. SpO2 is your oxygen saturation levels, and this is the fraction of oxygen saturated haemoglobin relative to the total haemoglobin in the blood. Make sure you are aware of target saturations for each patient to ensure we are not over or under oxygenating the patient. Some patients with chronic lung conditions, such as COPD, may have lower target saturations. These are usually 88 to 92%, and over-oxygenating these patients can be detrimental to them. Next, look at the respiratory rate. So your normal resting respiratory rate for a patient is between 11 to 12 breaths per minute. You should observe the patient's breathing pattern for abnormalities. Breathing patterns can alter as a result of many different things, such as pain, fatigue, and anxiety. Your work of breathing, or WOB, is the amount of energy or O2 consumption needed by the respiratory muscles to produce enough ventilation and respiration to meet the metabolic demands of the body. If someone has an increased work of breathing, their rest rate will increase, accessory muscles in the neck may become more apparent, and they will eventually get tired and ultimately will manifest into acute respiratory failure if no intervention is made. Therefore, observing how hard it is for a patient for someone to breathe is very important. Next, look at their arterial blood gases. Arterial blood gases are a type of blood test that give an indication of ventilation, gas exchange, and acid-base status within the patient. Then auscultation. So auscultation is an important part of your assessment as you can listen to sounds within the lungs as the patient breathes. This may give you an indication of sputum retention or volume loss. Palpation. So within palpation, you can do TF, also known as tactile fremitus. This is a palpable vibration produced during breathing caused by a partial airway obstruction. The obstruction can be due to mucus or other secretions in the airway. Then look at chest or thoracic expansion. You should check to see if the patient's chest expansion is equal. This is an important part of your assessment, as if the expansion is not equal and can identify possible pathologies. Asymmetrical reduced expansion may be related to a pneumothorax, pneumonia leading to lobar collapse, or a pleural effusion. Next, look at the patient's cough. Does the patient have a cough? And if so, is it effective at clearing secretions? When coughing, does it sound dry, wet, or restrictive? As mentioned previously, if a patient is heavily sedated or paralysed, they may not have a cough, or if a patient has a neuromuscular weakness, their cough may be weaker, meaning different methods of secretion clearance may be needed, or assistive devices may need to be used to ensure clearing of sputum effectively. Looking at the patient's sputum, so sputum can come in a rainbow of colours which may indicate different pathologies. For example, green is usually a sign of infection, whereas pink frothy sputum may indicate pulmonary edema. Monitoring the viscosity of sputum is important. If sputum is thick, it may be hard for the patient to clear and require drug therapies such as mucolytics or nebulizers to help make it easier to clear. Next, have a look if they have any chest drains in situ. So chest drains provide a method of removing air and fluid substances from the pleural space. The idea is to create a one-way mechanism that will let air/fluid out of the pleural space and prevent the outside air or fluid from entering into the pleural space. This is accomplished by the use of an underwater seal. Swinging is normal and reflects the changes in the pleural pressure as you breathe in and out. Bubbling reflects the amount of air draining out of the pleural space, usually occurs during expiration or coughing. It may also occur on inspiration if a big air leak is present. Investigations. So chest x-rays, CTs, ultrasounds, respiratory function tests. So a chest x-ray, have a little look. Has the patient had a recent chest x-ray? This can help aid and support our hypothesis and aid in making an appropriate treatment choice. Look for signs of volume loss or consolidation of fluid. CT and ultrasounds can both aid and support the clinical presentation of the patient, like a chest x-ray. Respiratory function tests can give you an indication of how well a patient's lungs work. They look at how much air can be inhaled and exhaled into the lungs and how well they absorb oxygen and lung volumes. PEFR stands for peak expiratory flow rate, and this is a person's maximum speed of expiration, as measured with a peak flow meter, a small handheld device which is used to monitor a person's ability to breathe out air. Lastly, have a little look at drugs. So nebulizers. A nebulizer converts the solution of a drug into a fine spray. You can then breathe in that spray. So nebulizers use oxygen, compressed air, or ultrasonic power to break up the liquid drug to deliver the dose you need. They can be used to relieve breathlessness, wheezing, chest tightness, and help aid in sputum expectoration. Common nebulizer drugs you may see: salbutamol, saline, and ipratropium. Mucolytics. So mucolytics are medicines that make the mucus less thick and sticky, in turn making it easy to expectorate. Common mucolytic you may hear or see of on drug charts is called carbamazepine. So now you've completed your assessment, you can look at all your findings and formulate the patient's potential problems. If these problems are physio-amenable, then you can formulate a treatment plan and go carry it out. And that concludes our multi-system assessment session. Thanks very much for listening. This PowerPoint very much just scratches the surface, and I hope it's given you a basic understanding of some of the things you may come across in a clinical area. If you're unsure and don't understand some things, go away and learn about them and ask questions once you're in a clinical area. Thanks, guys.